Pediatric shock is a crisis of delivery. When blood cells struggle through constricting capillary beds, they starve tissues of oxygen and trigger rapid systemic deterioration. At the bedside, this child is tachycardic, hypotensive, and mottled. For this exact scenario, the 2026 Surviving Sepsis Campaign pediatric guidelines now establish the international standard of care. For the clinician standing at the bedside, the update requires a specific set of changes to the way we treat this child. The 2026 update moves away from rigid algorithms toward physiologically guided resuscitation. To apply this in practice, we will track a patient's journey across 5 critical decision nodes, from triage to the intensive care unit. The value of these guidelines lies in applying continuous, real-time reassessment to individual patient physiology. The first node is recognition. Since 2020, hospitals have leaned heavily on automated electronic medical record alerts to trigger sepsis interventions. The 2026 panel now finds insufficient evidence to recommend these automated, systematic sepsis screening tools. Randomized controlled trial data shows that EMR-based screening provided no mortality benefit and did not improve how quickly antibiotics were administered. Automated screening relies on a hospital's specific environment and existing workflows, meaning its success is not universal. Finding insufficient evidence for screening does not mean clinicians should stop looking for sepsis. Instead, the guidelines advise developing highly localized, institution-specific triage protocols to identify acutely unwell children. Sharp clinical recognition and bespoke triage systems outperform generic automated software alerts. Once the patient is identified, the focus shifts to the initial diagnostic evaluation. This guideline flowchart maps out the initial management protocol. The panel issues a strong recommendation to measure blood lactate as a mandatory part of the evaluation. It earned this highest level of recommendation based on clinical utility, despite low certainty of underlying evidence. Under the updated Phoenix sepsis criteria, a lactate level above 5 millimoles per liter satisfies the requirement for cardiovascular dysfunction. Even minor elevations below 5 serve as physiological alarm bells, indicating insufficient organ perfusion. As this graph shows, clinicians must use lactate trims over time to judge the adequacy of resuscitation. We cross-reference this declining lactate curve against physical exam findings, such as capillary refill time and mental status, to confirm the patient is stabilizing. Lactate provides a continuous, objective feedback loop for evaluating hemodynamic stability. Moving to the center of the flowchart, we reach the continuous reassessment phase, following the initial delivery of fluids and antibiotics. Here, the guidelines issue a new conditional recommendation to utilize cardiac and lung point-of-care ultrasound, or POCUS. POCUS allows the treating clinician to visually assess myocardial contractility and pulmonary fluid status at the bedside. This data helps differentiate between overlapping shock phenotypes, separating hypovolemic shock from cardiogenic causes. This recommendation depends on local resource availability and the specific training of the clinical staff. POCUS provides a structural window to answer physiological questions when the physical exam remains ambiguous. If shock persists, resuscitation often stalls, waiting to establish a central venous catheter for vasoactive medications. The 2026 guidelines address this by recommending the initiation of vasoactive medications through peripheral venous access. This bar chart compares mortality outcomes. Meta-analysis data from 700 children shows early peripheral administration reduces the risk of death compared to waiting for a central line. While clinicians fear tissue injury, the actual extravasation risk for peripheral pressors is just 2.5%. Once access is secured, the debate shifts to the choice of the first-line agent. The 2026 update finds insufficient evidence to universally recommend epinephrine over norepinephrine as a first-line therapy. Clinicians should select epinephrine for low cardiac output and norepinephrine to increase systemic vascular resistance. The immediate speed of peripheral drug delivery matters more than achieving central access first. We now move to the post-resuscitation phase in the PICU, where the patient has reached baseline hemodynamic stability. Traditionally, fluid administration was viewed as a one-way street, where volume was continuously pushed to maximize perfusion. The new good practice statement prioritizes preventing excessive fluid administration and monitoring total intake. Observational data shows that excessive fluid overload links directly to prolonged mechanical ventilation and higher mortality. Once end-organ perfusion is restored, the focus shifts to active fluid removal through diuresis or continuous renal replacement therapy. Aggressive de-escalation must begin the moment hemodynamic stability is achieved. Sepsis care functions as a continuous loop, requiring constant reevaluation across the entire clinical timeline. These updates move away from the concept of a rigid, universal algorithmic track for every child. By utilizing conditional recommendations and good practice statements, the guidelines prioritize bedside clinical judgment. The primary advancement in this update is the relentless application of dynamic reassessment. Every intervention requires the clinician to ask, is this child improving, and what does their specific physiology demand right now?
Today, we are breaking down the newly updated 2026 Surviving Sepsis Campaign International Guidelines for Children. Now, I know this is a dense, incredibly comprehensive update built on a mountain of new clinical data, but don't worry. We're going to distill the whole shebang into 7 actionable, easy-to-grasp clinical takeaways. Whether you're just refreshing your knowledge or looking to really understand the core shifts in pediatric sepsis management, let's jump right into this explainer.
Here's our roadmap. We'll be moving step by step through system protocols, timely cultures, the antimicrobial clock, fluid resuscitation, the power of POCUS, vasoactive access, and early rehabilitation. Let's get started.
All right, let's dive right into our first crucial point, the overarching need for system-wide protocols.
Now, before a hospital can actually implement protocols, they need a shared language, right? Notice how the 2026 guidelines carry forward a very strict baseline definition. Sepsis is a severe infection leading to life-threatening organ dysfunction, while septic shock specifically involves inadequate perfusion. This shared language is absolutely crucial. Think about a chaotic emergency room environment. Ambiguity and defining sepsis is exactly what delays code activations and resource allocation. Having this rigid, universal definition ensures that when a systemic protocol needs to be triggered, every single member of the care team is immediately on the exact same page.
It's also worth noting that the guidelines elevate the implementation of standard operating procedures and performance improvement programs to a strong recommendation. And the observational data behind this is just incredibly compelling. When hospitals standardize their response, they see a relative risk reduction in mortality of 0.51. To put that into real-world terms, these protocols are essentially cutting the relative risk of mortality right in half. Plus, they significantly shorten hospital stays. It's a foundational, systemic step that literally primes every subsequent clinical intervention for success.
That brings us to point 2 on our countdown, timely cultures.
Securing a microbial diagnosis early on is a definitive pillar of sepsis care. Tracing the visual pathways of the updated algorithm down to the middle section here, you'll notice a specific good practice statement. It requires clinicians to collect blood cultures right at the recognition phase, concurrently with measuring lactate. Doing this immediately is the gold standard, because it establishes the ultimate roadmap to tailor antibiotics later on. It allows you to shift from broad empiric therapy to targeted treatment, which is absolutely vital for preventing antibiotic resistance.
But there is a massive real-world caveat here that we need to talk about. Picture a scenario in a super busy ER where a clinician is desperately struggling to find a vein in a severely hypotensive child. In that high-stress moment, the guidelines are definitively clear. You must never let difficult culture access delay life-saving antimicrobial administration. If establishing access is delaying care, the priority immediately shifts to administering those antibiotics through whatever means you have available. Getting the culture is a critical best practice for sure, but it can never stand in the way of immediate life-saving medical treatment.
Which perfectly transitions us into point number 3, the antimicrobial clock.
This is where urgency gets heavily quantified. The experts have established 2 very distinct timelines based on how the patient presents. For a child presenting with probable sepsis but without shock, clinicians are permitted a slightly wider 3-hour window. And honestly, this decision-making window is a brilliant protective measure. It gives clinicians time for rapid investigation, say confirming if the infection is just a standard viral bug, which protects the child from the unnecessary side effects of broad-spectrum antibiotics. But on the flip side,
For children with suspected septic shock, there is an immediate, unforgiving 1-hour goal to administer those antibiotics. The guidelines literally spell it out like this. For children with clinical evidence of septic shock, antimicrobial therapy should be initiated as soon as possible and ideally within 1 hour. The biological rationale here is undeniable. When cardiovascular dysfunction is present, the clock is absolutely your worst enemy. Retrospective studies consistently show that for these specific patients, every single minute counts, making that 1-hour mark a hard finish line that is directly tied to survival.
Moving right along to point 4, let's unpack the updated nuance around fluid resuscitation.
Focusing on the fluid bolus therapy pathways, the panel suggests administering up to 40 to 60 milliliters per kilogram of fluid over the first hour. But listen, this comes with a massive condition. This is only recommended in healthcare systems that have intensive care availability. The rationale here is deeply practical. Aggressive fluid resuscitation without immediate access to advanced airway management or critical care support, that can be disastrous if the child's respiratory status starts to rapidly deteriorate.
Now, when you do have the appropriate ICU resources, fluid should be highly deliberate. We're talking 10 to 20 milliliter per kilogram boluses, maxing out at that 40 to 60 threshold. But why this truly matters for the clinician at the bedside is this final point. You must continuously reassess for fluid overload. Fluid overload isn't just some minor complication to brush off. Clinically, it manifests as severe issues like pulmonary edema, which inevitably leads to desperately prolonged mechanical ventilation times. Aggressive fluids without constant, vigilant clinical monitoring can rapidly become detrimental.
Next up is point 5, which introduces a fascinating shift in how bedside assessments are actually being conducted globally.
Section 5 focuses on the power of POCUS, or point-of-care ultrasound.
Get this. According to the guidelines, an incredible 71% of the expert panel now utilizes some form of advanced hemodynamic monitoring. Because of this massive adoption, there's a brand new conditional recommendation advocating for cardiac and lung POCUS to guide initial resuscitation, and the difference this makes at the bedside is just profound. Instead of blindly giving fluids based on vital signs, a clinician can use ultrasound to visually see a poorly squeezing dysfunctional heart. Seeing that instantly changes your management plan. It shifts the focus away from pushing more fluids to perhaps starting inotropes instead. This incredibly accessible tool allows teams to rapidly differentiate shock etiologies, and it's actually associated with a shorter shock reversal time by an average of 24 hours. That is huge.
Let's move to point 6 and see how this logically builds right into vasoactive administration. Historically, there was a heavy reliance on waiting for a central line to be placed before administering powerful medications like epinephrine. But, as we all know, getting a central line involves significant logistical delays. You're gathering sterile equipment, using ultrasound guidance, waiting for specialized personnel. It takes time. Well, the Vital 2026 update conditionally suggests a total paradigm shift, initiating vasoactive medications via peripheral venous access to avoid those delays entirely.
The data finally proves that this shift is a life-saving game-changer. Studies incorporating over 700 children showed that avoiding delays by initiating vasoactives peripherally significantly reduced the risk of death. For decades, clinicians were held back by the fear of extravasation, which is when the medicine leaks and causes severe tissue injury. But this update highlights that the risk is remarkably low, sitting at just 2.5%. That minor risk is statistically vastly outweighed by the massive survival benefit of early drug delivery. Furthermore, it's entirely reasonable to initiate these vasoactives either before or after that 40 milliliter per kilogram fluid threshold we talked about earlier.
Finally, we reach point 7, expanding our view from the immediate crisis to the long-term horizon.
Point 7 introduces early rehabilitation bundles, moving far beyond the acute phase of care.
The guidelines now formally advise starting individualized rehabilitation bundles during the acute illness itself, rather than waiting for the recovery phase. What this actually looks like in a busy PICU involves targeted, non-technological interventions. It means physically turning down the alarms and lowering the lights to let a critically ill child actually maintain a sleep cycle. It means actively working to prevent delirium, minimizing heavy sedation, and safely getting a child sitting up on the edge of the bed even while they're on respiratory support. Connecting these profoundly human elements of care to clinical practice has been shown to tangibly reduce the duration of mechanical ventilation, changing long-term neurocognitive trajectories even in hospitals with very limited staffing.
The 2026 guidelines represent a holistic shift, from the immediate, unforgiving urgency of protocols and antibiotics to the nuances of fluid and ultrasound, all the way to early rehabilitation. But it leaves us with a really provocative question to ponder. How can healthcare systems globally shift their focus from merely surviving acute pediatric sepsis to truly optimizing long-term neurocognitive recovery?
It's a question that challenges every single healthcare provider to look beyond that initial hour of shock. Thanks so much for joining me on this explainer, and keep learning.